So these are your big DRGs for stroke, and I always break it up into two ways. So 23 and 24 are your surgical DRGs. So these are our mechanical endovascular therapies. In this bucket, it is to note as well, a lot of other things go in here. So you have craniotomies for subdurals, you may have craniotomies that had epilepsy or a DBS stimulator placed. But these are where all of your LVOs typically lie in your 23 and 24. And then, so your procedural stroke. Then your 61 through 69 is really your medical stroke. So those medically managed patients. And when you look at the ALOS, that's our average length of stay. Every hospital is different. Some of your DRGs, you may be above you may have a higher ALOS versus a lower, but this is from an organization where we're sitting at. Your geometric length of stay is really what Medicare and says that patient should be in the hospital for. So they kind of tell us, okay, well, if you have a large vessel occlusion and we go in and pull that out, you should need about 7.5 days of hospital time, depending if you have complications. If you don't have complications and you're in DRG 24, then you only should need about 4.2 days. What you think about that are stroke patients who come in, have endovascular therapy, spend at least one day, most of them in the ICU. Then they need to go to a step down. Then they need to go to a floor. And then you have to discharge them with a discharge plan by day 4. So it's really challenging. And without efficient pathways, there's no way that you're going to meet those benchmarks. And when we talk about our margins, and I think this is really important because you can see the disparities, right? So we know in stroke, the majority of our payers are Medicare versus commercial payers. Our commercials are like the private insurance that we have through our hospitals and through our work, non-government really insurances. So you can see the difference. If you look at DRG 23, your Medicare is only going to reimburse you from your margin at about $6,425 after you've had all of your expenses. So remember, your margin is cost minus payment, or payment minus cost, to give you how much you have left over that you have acquired for payment on that patient. So $6,425 versus if we have a commercial payer, it's $47,948. That is a huge disparity. And we're talking about the same care for the same patient following the same pathway. So when we talk about our patients, we need to really maximize through length of stay, through cost control, through standardization of evidence-based practice and care, through our order sets to really help us drive efficiencies within these patient populations. If you go down to DRG 67, you can see we have a negative margin on these patients. So every patient that we treat, we're losing money on that patient population. So how do we work through this, and how do we make stroke sustainable? Because we know more coordinated care, more resources are important, and it's really important to make sure we're moving patients through, especially now post-COVID, or some of us are still in COVID, some of us are post-COVID recovery. You know, financial organizations took a large hit. They've had a lot of financial struggles to be able to maintain care for patients. So right now, optimizing our care as well as controlling our costs are very important for us all to be able to be sustainable. Can you go to the next slide? So how do we optimize stroke workflow to impact the economics? So we talked a lot about that upfront workflow. And the quicker that we identify patients for treatment and the quicker we triage them to the right center, and make sure that we're treating them with the eligible patients for thrombectomy. I think some of our technologies such as Viz and some of our pre-trials, there was this huge population of patients that were eligible for treatment that we were missing. And now we have this amazing technology that can help us identify these patients quickly, start the transfer process, get them to the right center, get them to the angio suite much quicker, and really looking to increase that treatment rate with that accurate identification. So really wanting to break this down, you know, I think as stroke coordinators and previously being a stroke responder nurse out of neuro ICU when I worked there, everything was time for us. So What is 33 minutes? So we think of that 33 minutes is about how long it takes me to get to and from work here in Atlanta. In Miami, it took me about an hour and 33 minutes to go 6 miles, but 33 minutes is significant in a stroke patient. That equates to 132-day loss of disability-free life, 330 days of loss of functional independence. It's the difference between eating and being fed, walking versus being pushed, you know, talking about that disability component and losing that functional independence for patients. And also it's about 34,947 of median net revenue increase. So 33 minutes, when we talk back about those margins and the DRGs, this is what can come from that. So it's pretty significant when you relate it to that dollar component.